So I guess we'll get started. Whoever shows up, shows up. We're going to go over common prescription medications with a goal not being an exhaustive list, but more for what is going to help us do our jobs. So the objectives are we're going to discuss how to identify some of these. We're going to discuss the disease processes of what they cover. We're going to discuss a little bit about the pharmacology and what these drugs do. And we're also going to try and get understanding of the side effects that really affect us as EMS and things that we need to be mindful of when we see a prescription medication on the list. So we're going to go over the class of drug, so what it does, how it works. We're going to go over the recognition, so what are some easy ways to recognize that type of drug. Problems, so what it actually is used to treat. So if you hear a problem list or you hear a medication list, you can maybe start matching the two together, match problems with drugs, or vice versa, match drugs with problems. And then we're going to have some special considerations for each different type of drug. So kind of the origins, drugs are broken up into classes, and a lot of these classes have similar endings. For example, like beta blockers, calcium channel blockers, they're all kind of structured in a very similar way that have similar effects. There's your root word that we can use to figure things out. And then we also have prefixes, suffixes, as well as trade names and brand names. So an example of a brand name would be Bayer. The trade name is aspirin. And then we also have suffixes, which is the ending piece. And we're going to get into that in a little bit as well. So start with beta blockers. Who here is familiar with beta blockers? Have you heard of them? Yeah. Know they exist? That's kind of what we're going for. So they block the sympathetic nervous system at the heart and lungs, focusing on beta sites. So there's beta sites in your heart. Beta 1 is your heart. Beta 2 is your lungs. You've got one heart and two lungs. And we're going to maintain the heart within a normal range. And you're also going to adjust contractility within a certain amount as well. And also, because they're beta blockers, if they're non-selective, they're also going to block sites in the lungs. So they'll actually inhibit bronchodilation. That can be a bad thing. So if someone's on beta blockers and we need to bronchodilate them, we're going to have a lot harder time doing that. So we recognize them by looking for the LOL, or OLOL. Atenolol, esmolol, metoprolol is one that we've probably all heard because we carry it on the trucks. Propanolol and labetalol. Those are kind of the most common ones that are being prescribed these days. That's how you recognize it. It's just that LOL suffix is fairly common to beta blockers. Things it treats. Heart going too fast or blood pressure is too high. We're going to try and kind of restrict that heart, put a max capacity on it. It's kind of like putting a governor on A6. It can only go so fast. Same thing, beta blockers. Heart can only go so fast. Things we need to be thinking of with beta blockers specifically is it doesn't allow the natural compensation of the body. So if we have a patient who is in a trauma scenario, we have a patient who is in septic shock, or they're in shock of some degree, and their body says to compensate, the beta blockers will not allow their body to compensate. Their heart rate can't increase past that certain range. That can be a problem. They can become hypotensive as a result of the inability to compensate because of beta blockers. It also can worsen COPD and asthma. If they're having an asthma attack, they're having a COPD exacerbation, and they're on beta blockers, it's going to be much harder to stimulate those sites because they're being inhibited and blocked by the beta blockers. So those are very common. We need to be thinking about with beta blockers. Questions on beta blockers? How often do you guys see these? All the time. Yeah, literally all the time. Yeah, and metoprolol is probably the most common one that we see. Next ones are ACE inhibitors. So these are angiotensin converting enzyme inhibitors. And what they do is, I know, big fancy name, big long name. It blocks angiotensin converting enzyme from converting angiotensin 1 to angiotensin 2. And this is working on the renin, angiotensin, aldosterone system in the kidneys to regulate blood pressure. It's how your kidneys regulate blood pressure. And what we're doing by blocking that conversion from angiotensin 1 to angiotensin 2 is ultimately we're going to have a venodilation that's caused because when it converts to angiotensin 2, the veins constrict and that increases blood pressure. If we don't allow that conversion to happen, then we're going to get some venodilation, smooth muscle dilation in the venous system, and that's going to reduce blood pressure. So how do we know what these are? Yeah, absolutely. No such thing. Let me go back a slide. What's the question, Joe?
Angiotensin. What's angiotensin?
Angiotensin is a hormone that exists in the kidneys, secreted by the kidneys, and then angiotensin converting enzyme converts that from 1 to 2. And it's a whole process. It's like a 26-step process. That's a made-up number, 26 numbers, on the process it takes to regulate blood pressure by the kidneys.
So basically, it's just an enzyme that is
Exactly, yeah, it's an enzyme.
that's trying to block doing its thing.
Yeah, the big takeaway is that it causes venodilation by giving these meds.
Causes what?
Venodilation, so venous dilation. So we recognize them by the ending pril, P-R-I-L. Lisinopril is probably the most common we see there. There's also captopril, enalapril, and ramipril. Those are some more common ones. And there's a whole long list, but these are the 4 most common. Lisinopril being the absolute most common. We see this all the time.
So this causes dilation. It's not really good for hypertensive patients.
Oh, it's good for hypertensive patients. Correct.
Hypo.
Correct, yeah, hypotensive patients. It's a very subtle dilation. It's not as profound as, say, nitroglycerin.
Okay.
They work on different. It's very, very subtle dilation. So, things it's used for. Hypertension, heart failure. Because in heart failure, there's an increase in afterload, which is the kind of the force of the heart has to push against. So we're going to reduce the afterload, make it easier for the heart to pump. Coronary artery disease, again, it's that little bit of relaxation, smoother flow. Diabetes, again, in diabetes, it's used mostly for the peripheral vasculature at the fingers, toes, because they have that diabetic neuropathy. So it's to open the vascular space up a little bit and promote blood flow. Chronic kidney disease, again, to open things up, promote blood flow. And then also it's in heart attack to kind of keep that blood pressure within a certain range, bring it down a little bit. And these are all the fun stuff, all our special considerations.
Joe,
Yes.
we're leaving.
The biggest special consideration here to factor in is by far angioedema. Lisinopril and other ACE inhibitors, we're not sure why they cause them, but it causes a massive angioedema, swelling of the tongue, of the oral airway, and epi does not work on it. Benadryl might work a little bit, steroids might work a little bit, but really it's time. And with angioedema, these patients typically get criked. And it's a bloody mess. Or you catch it in time early enough and they can get intubated, hopefully before. And usually this can progress. It's either a sudden onset for some of them. And there's even been cases, though, thankfully, where this will progress multiple times with each occasion getting worse and worse and worse. Or it's a slow accumulation and the patient realizes, oh, my throat's closing up. It was a little bit closed yesterday, it's more closed today. This might be a problem. And they get checked out and they've got an ACE inhibitor, usually lisinopril caused angioedema. Can give them a dry cough, just kind of that consistent cough. Increased potassium levels, so you can be worried about cardiac issues with the hyperkalemia, the high potassium. If that blood pressure goes too low, they can have a syncopal episode, and they can also get dizzy, and that's not good. There really aren't any reversal agents to ACE inhibitors other than time. So you have to manage them other ways. to maintain that blood pressure until the drug is metabolized and out of the system. NSAIDs, it reduces the effectiveness of ACE inhibitors. So if someone's taking, say, ibuprofen every single day for chronic pain, they may need to increase the doses of the ACE inhibitors to actually have an effect. It's going to reduce the effectiveness of them. And then they should never be taken with ARBs, so angiotensin receptor blockers, or DRIs, which are direct renin inhibitors. And those are other blood pressure control medications that work kind of on this renin, angiotensin, aldosterone system. So you double them up a little bit. Let's say you tighten the brakes in your car and you put a governor on it. Or you restrict the amount of distance that the gas can travel and you apply the brake all the way on. Nothing good comes from that. So we're basically doubling up on hypotensive medications, on blood pressure reducing medications, and that can not end well for the patient if that happens. Next up are NSAIDs. Who is familiar with NSAIDs? We all should be. Everyone in EMS typically takes NSAIDs on a daily basis for our chronic back pain from lifting all these large patients. We should be intimately familiar with NSAIDs, and they are an anti-inflammatory. They also function as an antiplatelet, and they work on prostaglandin. So there's COX-1 and COX-2. COX-1 is cyclooxygenase 1. COX-2 is cyclooxygenase 2. And some of these meds are selective COX-1, some are selective COX-2, and others are non-selective. Aspirin is a non-selective. It kind of goes right in the middle of the road, affects both COX-1 and COX-2. COX-2 is mostly inflammation, pain, and platelets. COX-1 is GI motility, platelet production in the GI tract for GI protection, stomach lining protection. So we get platelet aggregation there. It forms that nice mucus lining in the stomach to keep our entire GI tract from eating itself. So if you start inhibiting those COX-1 receptor sites, there's less GI protection. So that's why we can get that GI upset from these NSAIDs, especially if they're non-selective or COX-1 selective. They're going to be causing a lot of that GI upset because we don't have that GI protection. It's where this peptic ulcer disease, stomach ulcers come from, is from inhibiting this COX-1.
Can it lead to GI bleeds as well?
Absolutely it can. Absolutely it can. That's why you're basically told that you pick one NSAID and you take it. You don't mix, say, Aleve and ibuprofen. You don't mix the two of them. But you can take Tylenol as well. If you're taking aspirin, you don't want to take aspirin and Aleve and ibuprofen because they're all going to be working along the same pathway. So most NSAIDs are non-selective. But ultimately, it is prostaglandin inhibition, which is how we get that platelet blockade. The way this works is once you give the drug, once they ingest the drug, all the platelets in the body are affected, and they are irreversibly changed to non-aggregate until the next cycle. So you give aspirin. Aspirin actually has an effect for about 3 weeks. Platelets are non-aggressive, non-aggregating for about 2 to 3 weeks. Because during that time frame, your body has to reproduce the platelets, and all the platelets currently there have a chemical change that occurs that means they will not aggregate. So how do we recognize these? There's a lot. There's a lot of NSAIDs, and there's some newer age NSAIDs that are much nicer. So Profen is one of them. Ibuprofen is an example. Fanac, so diclofenac, actually it's very commonly prescribed in European countries instead of ibuprofen. And then there's Coxib. And Coxibs are COX-2 specific NSAIDs, so they don't have as many GI effects. So Celebrex is a COX-2 specific. Mobic or meloxicam is also COX-2 specific. Those are kind of these newer age NSAIDs that are much better for us. So there's piroxicam, meloxicam, and then that last one over here, that's the Celebrex, celecoxib. Ketorolac or Toradol is also an NSAID, and that's actually more on the COX-1 side. So when we give Toradol, or we see someone that has received Toradol, it is very aggressive and agitative on the GI tract, but it does a really good job of getting rid of that inflammation. So problems, what does it cause for? Mild to moderate pain and cardiovascular problems, specifically MI and platelet aggregation. So some special considerations: GI upset, peptic ulcer disease, and they can also exacerbate asthma. Because we're reducing those prostaglandins, we reduce the surface tension of surfactant. Surfactant is almost washed out and not as effective because we reduce the prostaglandins, and then we start getting alveolar collapse.
I wonder if most people with asthma know that when they take an NSAID.
Probably not. Probably not.
Probably not.
But it reduces the surfactant, the surface tension of the water in our alveoli is kind of splinting them all open, collapses, and then we get alveolar collapse, which can worsen that asthma attack. Anticoagulants. This is kind of big for us to know in EMS. How often does Granny fall down and they spout out some med and you're like, I've never heard of that before in my life? On a pretty regular basis. So our goal here is to prevent prolonged clotting time and prevent blood clots. There are the parins, coumarins. So parins are like heparin and Lovenox. They're both heparin based. We also have Coumadin and warfarin. And then we have these new age medicines called direct oral anticoagulants, or DOACs. These are rivaroxaban, which is known as Xarelto, and apixaban, which is Eliquis. Those are two very common new age anticoagulants. We're seeing them all the time. They don't require testing. The patients love them. The doctors love them. It has a known effect, but there's no reversal agent. So no reversal agent means that you have to actually wait for the drug to get metabolized and hopefully clotting resumes. And usually that's after their head injury has killed them because they bled out. And then we have these direct thrombins. So bivalirudin is one that's very old. We also have agartroban and then Pradaxa. Pradaxa is a new age. Pradaxa is a nice one. We see Pradaxa a whole lot more, and Pradaxa has a reversal agent called Praxbind. But bivalirudin and agatroban, those are kind of older direct thrombins. And those were used for years and years in cardiac cath labs, using for years and years as post-MI, post-CABG care, as an anticoagulant. But we don't really see them that much anymore. Pradaxa is the one we see the most of as a new age. But it has a reversal agent, so it's nicer. There are certain kinds of mechanical valves that they don't want to use Pradaxa on. It won't have a similar effect. They still want that Coumadin or warfarin is what they're commonly using for mechanical valves. And any kind of mechanical stuff in the body, they're using Coumadin. AFib is mostly, can be Xarelto, Eliquis, Pradaxa. I've seen all of them. So mechanical devices in the body. CVA is, you might see this as well. Usually it's Xarelto or Eliquis. You hope it's one of the ones that can be reversed. It's used post-cardiac arrest during that initial process to prohibit aggregation of clots and formation of clots and worsening of the condition. And then it's also used for AFib to prevent a CVA or a DVT. Depending on where those clots are forming, where they're going, we really want to prevent the clotting process if they're an AFib. Goes without saying, anticoagulants, they prolong clotting time, which means more bleeding. That's a bad day for patients, especially if they have a significant head injury, significant trauma, and they're taking one of those new age direct oral anticoagulants that has no reversal agent, there's not much we can do for them. We can try and replenish clotting factors, but there's not much the ER can do. There's not much us and EMS can do. There's not much the surgeons can do. They're going to bleed and bleed and bleed. We can have DIC with too much anticoagulant. The body is trying to use up its clotting factors. We get out of that, and then we have disseminated intravascular coagulopathy, and clotting doesn't happen at all. And they need clotting factor replenishment. Some reversal agents. Protamine sulfate is the reversal agent for heparin derivatives. Vitamin K, and then factors 2, 7, 9, 10, and protein CNS. For the drug Kcentra, that's what Kcentra is. It's all these clotting factors that we can replace. And that's the reversal agent for coumarin. So that's Coumadin, warfarin. And then Praxbind is kind of new age for Pradaxa. And then if they're also taking antiplatelets, so aspirin specifically, or even Plavix, those are two others that are on the platelet side of things for anticoagulants. We can give desmopressin, and desmopressin is what they use for that. But really the biggest thing is they bleed more, and we need to keep in mind of try to identify what drug they are on and determine if there's a reversal agent available for it or not. Because if there is, we want to tell the ER right up front, hey, they're on this, we're thinking this. That way they can get that reversal agent out and hopefully prevent them from bleeding to death. Otherwise, wait and see. Antidiabetics. These are ones that we probably know the least about in EMS because there's so many of them. There's new age ones, there's old age ones, and there's the ones that have just been around forever, and we don't deal with these on a regular basis. We don't know enough about them. But the purpose of antidiabetics is to really do one of three things. It's to increase insulin sensitivity in the tissues, which means that the body responds better to insulin. That's for your type 2 diabetics. It's to reduce gluconeogenesis in the liver, which reduces the conversion from glycogen to glucose. That's going to bring the blood sugar back up and skyrocket it. So again, that's going to reduce the blood sugar, maintain it in a normal way. And they're going to promote absorption of glucose into the cells. That's with insulin. So our type 1 diabetics, allowing insulin to act as that key to allow glucose into the cell. Recognition. There are a lot. There are a lot of antidiabetic medications. The first ones are insulins. And these promote the absorption of insulin, the usage of insulin, and the use of glucose. There are really three kinds. I listed two here. There's rapid, intermediate, and long-acting insulin. This is an issue because if the patient takes the wrong kind of insulin, now we have a problem. If they take too much short-acting, that's an easy solution. We know it's going to come off soon. We can bump their sugar up and maintain them. If they took too much of their long-acting, such as Lantus, that's a problem.
But do most patients have both and use both? And
Yes.
To determine, okay.
Yeah, they've got both. So they'll take the Lantus in the evening to maintain a basal rate, and then they'll take their short-acting after meals to bolus for each meal as they count. And if they take too much Lantus, then we're dealing with a multiple hours long trying to maintain their sugar within normal ranges. Then we have the biguanides, and these reduce gluconeogenesis and they increase insulin sensitivity. The big one here is metformin. There are two others, but the FDA has discontinued them because of lactic acid toxicity. And metformin also has the ability to cause lactic acid toxicity. And then there's our sulfonylureas. They increase insulin production. So these are things like glipizide, glyburide, glimepiride. The last ending is IDE. They increase insulin production to be used.
Jeff, what about Victoza?
There's a whole lot more. I'm not sure where Victoza falls. Is that one that you're more familiar with?
It helps with producing more insulin,
Uh-huh.
but it's not a.
Yeah, I saw Victoza was thinking about being discontinued.
Because Victoza is one other that's a.
It's very.
Victoza's an everyday injection.
Okay.
And then there's another one, I can't think of the name off the top of my head. It's a once a week.
Once a week. I'll have to look those up, and I'll send out an email update on those because I'm doing some research on them for sure. Then we have these right here. And these all kind of work to decrease gluconeogenesis. These aren't the common ones. The most common ones are the metformin, the glipizides. As Jay just said, the Victoza is kind of new and upcoming, and then insulins.
Where does gabapentin fall in there?
Gabapentin, I don't see, it's not a specific anti-diabetic. Look it up real quick. Gabapentin is more like an anti-seizure in pain. So it'd be used more for like the diabetic neuropathy.
Ready to go now. Now what about furosemide?
Furosemide, we're going to get into that, but that's not anti-diabetic. We're going to get into that in a couple minutes. Good question, though. So the problems it causes that we're working on is we have GI upset caused by all of these. We can have unexplained weight gain or weight loss depending on which antidiabetic we're using, whether it reduces gluconeogenesis or promotes insulin use. We can have weight gain or weight loss. Patients have nausea. Risk is always hypoglycemia because they're taking medications to bring their blood sugar down and maintain it to keep it from spiking up. And metformin can cause significant lactic acidosis. So what metformin specifically does is metformin works on oxygen. And during glycolysis in the mitochondria, that last stage is powered by oxygen to carry that last electron through the transport chain. We get pyruvate, and we get NADH and FADH, so riboflavin and niacin. And what metformin does is it prevents that from happening in the liver. So the liver essentially converts to anaerobic metabolism. So that pyruvate becomes lactate. Because that oxygen becomes lactate. And as that lactate builds up, an issue with this may be metformin is used all the time. It's a very common medication. It's also called glucophage. And with metformin, when you get that lactic buildup, if it can't be cleared out, so a patient who is in kidney disease, kidney failure, their kidneys aren't working, they can't filter the lactate out, and they get a profound lactic acidosis, causing a metabolic acidosis because of the metformin. And that's the reason that the other two medications that were like metformin were taken off the market in the US was because they had complicated morbidity and mortality because of lactic acidosis. And metformin is somehow the only one that made it kind of through those trials and tribulations. So metformin is a very dangerous medication. It's for people that have working kidneys, it's fine. But if their kidneys aren't working, they can't clear that lactate, because what it does to prevent gluconeogenesis is it basically shuts the liver off and says, you're not going to do your job. You're not going to work under aerobic conditions. You're not going to use that oxygen. So it prevents that oxygen from actually binding in the liver to create more glucose. So that can be a problem. Now we're going to get to corticosteroids. We see these all the time. And they can be a significant issue if we don't know what they're on them for. So corticosteroids act as a slight immunosuppressant, and they also work as an inflammation reducer. So ozone and olone are the common corticosteroids. So dexamethasone, we carry that. It's a common one. Prednisolone, prednisone, hydrocortisone, and methylprednisolone. A lot of us have seen a lot of those in EMS. We give them in EMS on a regular basis. They're typically used for asthma, COPD. They can be used for allergies. Can be used for skin rashes, arthritis, anything that really works on inflammation, joint pain, arthritis. And then also for adrenal insufficiency, because they are a steroid, they mimic cortisol, which is released by the adrenal glands. So we actually were mimicking a steroid, a natural bodily occurring steroid is what we're mimicking with these. So special considerations, they can cause a cough. They can have insomnia because it's working like a steroid. It increases things. It's like the adrenal glands, like adrenaline. It's not a sympathetic mimetic, but it's very similar to it's a steroid. They can cause high blood sugar because it prevents sugar from being processed and reduced. Especially diabetics that are on steroids, they can have very high blood sugars that don't get maintained well. Significant amounts of acne can occur. Water gets retained and there's significant weight gain. Wound healing is delayed. The entire clotting process kind of slows down a little bit when we have steroids. They can cause hypertension because everything kind of starts to clamp down a little bit. And then we can have significant mood changes. People get angry, get combative. They don't know who they are anymore. Steroids, especially corticosteroids, can have a significant impact on the person taking them. So we should be aware of those, especially when it comes to kind of that high blood sugar, that weight gain. Those are normal findings. Next, we have diuretics. This is where Lasix comes into play, or furosemide. So we have these loop diuretics. There's a bunch of diuretics. We've got loop diuretics, which kind of absorb sodium, is inhibited. And these are in the ascending nephron, in the loop of Henle, in the kidney. So you reduce that sodium reabsorption, water follows salt, and we pee it out because it can't get absorbed back into the body. It gets pushed down into the ureters, and water follows that salt. Thiazides. So these are in the distal convoluted tubule, and they inhibit sodium and chloride reabsorption. So not just sodium, but sodium and chloride. And they send that away, and again, water follows that, and they pee it out. Then we have this carbonic anhydrase inhibitors. So these have decreased sodium absorption and bicarbonate as well. So it's sodium and bicarbonate that they inhibit the reabsorption of. There are potassium-sparing diabetics. So these are like aldosterone antagonists or epithelial sodium channel blockers, so they'll block sodium channel. And what these do is when they function, potassium is still maintained in the body. So these are in our benefit. These are some thiazides, and the carbonic anhydrase inhibitors both work as potassium-sparing diuretics. We don't have to worry about a low potassium state. If anything, we're more worried about a high potassium state. And then we have osmotic diuretics. So osmotic diuretics, they increase serum osmolality. Extracellular fluid volume is expanded. So make that shift from the cells to the intravascular space. It's a volume expander. But they essentially diurese the cells. Take water from the cells and they kind of relocate it into the interstitial space or into the vascular space. So mannitol is an example of an osmotic diuretic. So how do we recognize these? Semide. S-E-M-I-D-E, furosemide, which is Lasix. And Lasix, there is a high risk of potassium being low. It is a non-potassium sparing diabetic. So low sodium, low potassium in the body. Chloride is maintained. And then there's torsemide, and they're both loop diuretics. Hydrochlorothiazide, it's also abbreviated HCTZ, is a thiazide diabetic. That's a diuretic. It's a potassium sparing. That's in our benefit. or the patients benefit to retain that potassium. And then we have amide, so acetazolamide, which is Diamox. That's a carbonic anhydrase inhibitor. Then we have spironolactone. Spironolactone is a potassium-sparing diuretic, and we see that very commonly in CHF patients. Spironolactone is one of the ones I've been seeing more and more of lately. I swear I didn't even see it used 3 to 4 years ago, and now I'm seeing it more and more often. So that's one that we should be aware of as linking to congestive heart failure is spironolactone. Mannitol and glucose are both osmotic diuretics. They make that fluid shift by osmotic pressure. And then we have caffeine. Caffeine is a xanthine, and it causes increased glomerular filtration rate, and sodium reabsorption is decreased, but that's it. It doesn't affect potassium. People just pee a bunch, and that's what caffeine does. It is technically classified as a diuretic. Exactly. Everyone in EMS is taking active quantities of diuretics, high doses of diuretics every day. So problems they cause. We want to fix systemic edema, make that fluid shift and get fluid offloaded. The body naturally wants to reach equilibrium between the cells and the vascular space. So as we start losing vascular volume, the fluid's going to shift from the cells and interstitial space into the vascular space and kind of make that equilibrium happen. And by doing that, that's how we diurese people. Hypertension, you reduce the volume, you reduce the blood pressure. Kind of like that fire hose. You take half the volume, now the pressure's less. There's less force exerted on those walls of those vessels. Used for heart failure, again, to reduce that preload, reduce that afterload. Used for liver cirrhosis. Again, you want to avoid that hypertension, that constant high pressure, so we're going to reduce that pressure with diuretics. Can be used for kidney diseases to promote function and flow through the kidneys. During kidney disease, kidney dysfunction, the things the kidneys need are fluid flow. The kidneys repair themselves by working. So if the kidneys don't have good perfusion, the kidneys don't have flow going to them, they're going to fail and they're not going to work as well. So we start diuresing these patients, it improves flow of fluid through the kidneys and makes them work harder, thus repairing them. And then poisonings. If we have a significant poisoning such as Tylenol or aspirin, we can give diuretics to process those byproducts through the body faster and hopefully reduce the effect of the poisoning. So special considerations are hypovolemia for loop diuretics and thiazide diuretics. So that would be Lasix and HCTZ is the two most common ones. Hypokalemia, so low potassium, for loop diuretics, thiazide diuretics, and acetazolamide. Hyperkalemia for spironolactone. You'd hope that if they're taking a kind of a combination here, they may just even themselves out between HCTZ, Lasix, and spironolactone. They might even themselves out, and hopefully you won't have a net increase in potassium or a decrease in potassium. We have low sodium if we have thiazide diuretics or Lasix. So we can have that low sodium because they doesn't reabsorb it, it kicks it out, and now we've got low sodium problems. We can have a metabolic acidosis or metabolic alkalosis, depending on which one we're having, because it's going to make that strong ion change. The sodium's going to change, the chloride's going to change, and as we change that, they act as either a weak acid or a weak base, and then we have acidosis that can occur. We can also have hypercalcemia with thiazide diabetics. Calcium stays in the body and can increase to dangerous levels. And then with thiazide and loop diuretics, we can have hyperuricemia. So bacteria in the urine or bloody urine through thiazide and loop diuretics. Questions, thoughts, comments? There's a lot there. And this is not an exhaustive list. I really just picked 7 classes of drugs and went with it.
Yeah, I mean, the numbers of medications that we see.
They're astronomically high.
Yeah, I usually just run down the list of the patients, particularly if they give me a printed list, and if there's 3 or 4 that I don't know, which there often are, why do you take this one, why do you take this one? So I get a sense of, what class they are, what they're taking them for, what their, medical problem is that they're taking them for.
Yeah, exactly. And the worst you can do is not ask.
Yeah.
If you ask them, it's not a big deal.
Yeah.
You ask what they're taking, and you find out.
Except for if they're psych meds, a lot of times people are a little chagrined
Right.
to be upfront about it.
That's kind of on the next topic. Would definitely be like a psych med,
Yeah.
just pure psych meds, and that's it. Because there's so many variants on what they do between all of those, or don't do exactly.
It's another common one. A lot of antidepressants, you see.
Yeah, and between antidepressants, mood stabilizers, antipsychotics, there's so many of those.
Yeah, that would be a good one.
That would be like a month-long course.
Yeah.
It'd be long for sure. Absolutely, it'd be long.
And can we have a table of them all as a week?
I know, right? We can try them out.
Try before you buy on psych meds. That'd be fantastic.
Or norms.
Yeah.
Right. Absolutely. You guys up in D2? Any questions up from you guys in D2?
Oh gosh, we're being listened to.
Well, someone's always listening to this.
Big Brother's watching. Absolutely. Any other meds that you guys think, other than psych meds, that would be beneficial to go over?
I missed the beginning part, so you probably.
The beginning part, we started off with beta blockers,
Okay.
and from there, I think we went into ACE inhibitors, talking specifically about lisinopril and the angioedema it can cause. It's never a good day. Well, I think we'll stop recording.
Yeah, it was good, thank you.
I did not give my consent to be recorded.